Good evening. Thank you for joining us for the 2024 End of Year Immunisation Update. My name is Phoebe James. I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I'd like to acknowledge the traditional custodians of the lands that we're all meeting on. We are broadcasting to you today from beautiful Awabakal land and pay my respects to elders past, present and any First Nations people joining us tonight. Just some housekeeping. Q&A, we have the wonderful behind the scenes girls that are going to be answering your questions as they come through. So please make sure that you bombard them with questions. If you want your certificate for this evening, for your CPD, please fill out the evaluation that will become live at closer to the end of the session. But do keep in mind that you don't need a certificate to self-report, but if you would like one, that's how you go around getting one. So you don't get sick of us, around 7:30 we will have a break. I say 7:30, but it's going to be more around how long our presenters present for, but that's the aim, around 7:30, so you can get another cup of tea or fill up your glass of wine and come back and join us. And now it is my pleasure to introduce the wonderful Sharon Saxby, who is a clinical nurse consultant immunisation with the Hunter New England LHD Public Health Unit.
Thank you, Phoebe. What a lovely welcome. We'd like to really welcome you all tonight as well, and thank you for giving up your time tonight. We know that night time is really precious. We hope you're all comfortable on the lounge and settled in for a night of really great information. Just want to make a note that we really value your questions. So your questions let us know what you need and what information you need and want, so we can help design our resources and what information we feed back. So please add any questions to Slido, and Kirsty and I will be monitoring Slido and attempting to answer all those later tonight. So just to introduce our team here tonight, so we have the fabulous Katrina Clark, who is our Aboriginal Immunisation Manager. She'll be speaking on some research that we're doing currently at the moment. Then we have the fantastic Megan Vidler, who this is her first night presenting with our team. She's a clinical nurse consultant with the communicable diseases team. Then we have the lovely Kylie Pratt, who works for Hunter New England Kids, HNE Kids, with the immunisation clinic up there. So she's been doing some absolutely fabulous work that she's going to let you know all about tonight. And then Kirsty Waller, she is just absolutely fabulous, our clinical nurse consultant who sits in Armidale with the immunisation team. So you're in for a treat tonight, guys. I'm going to open up tonight just talking about how we're going with our immunisation rates. You hear us talk about this all the time, and I think you will all know that this is really important, that we keep having a look at our rates, see how we're going, because we know that it's not a very good climate out there at the moment with immunisations. So I love this quote from Melinda Gates. You can have the best vaccines for a woman and her child, but if you can't get her to come and get them, they're not going to work. And I think that's very true. I'm going to start tonight with just a little bit of a story to set in context our night. So this is Laja. She works in South Sudan. She's a community health worker. Every day, or once a week, she gets on her bicycle and pedals as far as 10 miles from her small village in South Sudan. Some weeks she's doing outreach, spending her day educating the community about which vaccines she can provide and what diseases they prevent. She says it's her responsibility to tell the mothers to bring the children for vaccination. She answers their questions and lets them know that when she comes back, usually the following week, she'll vaccinate their children. Then late in the evening, she heads back home. When she returns the next time, she comes on her bicycle with her vaccines in a cooler with ice packs. She spends the day immunising anywhere between a few and 200 children against a whole range of diseases. Diseases that most probably in high-income countries we don't see anymore. But the people in South Sudan know them very well, and many have seen family and friends die from these diseases. During the rest of the week, Laja works at the community health centre in her village, monitoring the solar-powered refrigerator and the vials inside. She vaccinates anyone who comes to the facility and mets out drugs for a few maladies such as ulcers, malaria, typhoid. The village doesn't have any antibiotics or electricity. Villagers grow their own food, raise their own goats and chickens, and get water from wells in the ground. When it rains on travel days, She and her outreach pamphlets get soaked, but she must regularly check the temperature of the vials in the cooler and replace the ice packs at just the right time to ensure the vaccines don't go off. It's not easy work for $102 a month, especially when sometimes it takes her 3 months to get paid. This young 25-year-old mother of two does life tough, but she's dedicated to vaccines. So you can understand that the perception of risk of disease is really high in Sudan, but when that risk of disease is low, so in Australia and in other high-income countries, we don't see the significance of health impacts of some vaccine-preventable diseases because we've had long-term successful high-quality vaccination programs. So for example, endemic measles transmission has been eliminated in Australia, but we still get measles importations, which we see every now and then with alerts. In countries with robust vaccination programs in South Sudan, vaccine-preventable diseases such as measles continue to circulate in the community, as you can see here on that slide, where devastating impacts, including death, are very visible to families and communities. The perception of disease risk is high when diseases are circulating. On the contrary, when there is a low perception of risk of disease, like in Australia, there is a chance that the perception of risk with vaccination becomes greater. This poses a real challenge for us in Australia, as the best way to continue protecting our community from vaccine-preventable diseases is to maintain a high vaccination coverage. Among these things, like practical issues such as equity and access, maintaining community confidence in vaccines and ensuring people have accurate information is a priority for our service. And we as a team cannot stress enough the critical role that you guys all play in providing critical and reliable information around vaccines and helping maintain vaccine confidence. So I think that puts in perspective why we place so much importance on our rates. We don't see diseases like measles in Australia very much anymore, only from imported cases, but we need to maintain our high vaccination rates. Otherwise, we're going to see these diseases continue to appear or start appearing again. This is a really good article if you ever have the chance to look it up. It looks at the last 50 years of successful vaccination programs across the world. So give that a go and you'll enjoy that article. How are we going in Hunter, New England? So we look at these each time we do an update. This is our 12 to 15-month-old children. And as you can see, our rates are dipping off down the bottom. Except for our little Aboriginal kiddies at this point, they actually increased by about a few points of a percent. But that gap is pretty wide, isn't it? The blue is Aboriginal children, the red is non-Aboriginal. And we've got that gap that's really opened up again. So this is looking at your 6-week, 4-month and 6-month vaccines. Our 24 to 27 month is looking at all our vaccines all the way up to 18 months. So this is where we're looking at both our doses of MMR vaccine, and if you look at the end of that graph, we're starting to dip off. So we need around 94 to 95% coverage of measles in Australia to have really good herd immunity and prevent the re-emergence of this disease, which becomes a bit of a concern when we're seeing imported cases. So you can see down the bottom that all of our Aboriginal and non-Aboriginal rates have dipped in the last little quarter. At 60 to 63 months, we need to be careful with the really high numbers on this one because we're only measuring the 4-year-old vaccine, so the DTP IPV. So these numbers are not necessarily accurately recording all the different vaccines. But as you can see further, a couple of years ago, we had a really good gap. And here we have a reverse gap. So the Aboriginal kiddies are actually vaccinated at a higher rate than our non-Aboriginal. And we had a really good gap there for a while, but it is closing and it's getting closer and closer to being the same. I'm doing a lot of hard work. Just a really brief look at influenza vaccination for New South Wales. Just so we can see on these graphs, I've only got the 6 months to 5 years and 5 to 15 and then the over 65-year-olds. But you can see in the children, in 2020 we had really good vaccination rates. Okay, our first year of COVID. 2024, in the under 6 months, we're almost down below lockdown period of 2021. So, things are not looking so good. So we need to do a little bit more work in the coming years of getting people vaccinated for influenza. That's all people, and this is our Aboriginal and Torres Strait Islander people. Still, we have a really considerable gap. We haven't picked up. 2024 is along the bottom of those graphs. So more work to be done, but that's next year now. Anyone can find this data. Okay, NCIS data. Familiarise yourselves with NCIS to get lots of vaccination data. Have a quick look at the New South Wales school vaccination program. This is just Hunter New England data. The school program is really seeing a continuing decline of consents provided by parents for these vaccinations. So you can see there in the dark green is 2024. So consents provided, we are seeing less and less consents provided, which of course is going to equate with less vaccinations given. The only improvement that we've made is with meningococcal ACWI in 24, where we got an extra 5% of kids vaccinated, which is really interesting. Mind you, consent returned doesn't mean that we actually get the kids vaccinated. So that's why there's that little bit of improvement there. But school vaccines is an all providers problem. So if people turn up, adolescents turn up to your facility and they have either mentioned that they've missed their school vaccines, or you're actually really proactive and you discover that they've missed their high school vaccines, please offer those vaccines to them. Don't rely on air saying whether they're due or overdue, because we can see that HPV and DTPA is not actually due on air until the age of 14, by which time these kids have moved into year 8 or year 9. So if they're in year 7 or in year 10, they haven't got a record of these vaccines, offer them and vaccinate, please. We just have to remember that your recommendation to vaccinate is really, really powerful. People look at you as a trusted provider of information and a source of truth about vaccinations. So those conversations are really, really good. And things to lift your vaccination rates, we talk about this all the time, and I know it gets really hard, but consider allowing families to drop in for vaccinations or doing opportunistic vaccines. You know, one child comes in, there's another child there with the parents. Have a look at all their vaccination records and see if you have the opportunity to offer vaccines that are due or overdue. Sending out reminders, emails, SMS. While they're there for that appointment, make the next appointment for them. If they've got a date, they're more likely to keep it than just saying, come on back at any time. And just to remember that Sky has some really good resources on having those conversations with parents. So if you're hesitant about having a conversation with parents about encouraging them to vaccinate, have a look at Sky, look at their resources. They've got some really wonderful things there. So just remember, our immunisation conversations are more important now than ever, with our vaccination rates declining, and our relaxing attitudes towards vaccination leave us all at a great risk of disease re-emergence with decreasing vaccination rates. So keep up the good work, guys. You do a wonderful job and you are indeed lifesavers. Just going to hand over to Katrina now.
So good evening, everybody. So this evening I'm just going to be touching a little bit on some research that is happening here in the Hunter New England immunisation space. And prior to starting my presentation, just want to acknowledge as well that all the research that I will be speaking about have all been approved by the New South Wales Aboriginal Health and Medical Research Centre Ethics Committee, as well as the Hunter New England Local Health District committees. So my first research project that I'm going to be talking about is the keeping mobs safe. So it was understanding of vaccine and having a supportive conversation. This study was aimed to assess the appropriateness and the acceptability of a tailored vaccine conversation workshop with Aboriginal and Torres Strait Islander and non-Indigenous people who provide services to Aboriginal and Torres Strait Islander communities. And we call these workshops Keeping Mobs Safe, yarning about vaccines. Our method was to adapt and indigenise an existing workshop. So the workshop was adapted and indigenised from a COVID-19 vaccination workshop that was developed by Professor Julie Lease in 2020 for communities, recognising the decline in childhood vaccines and other vaccination coverage for Aboriginal and Torres Strait Islander peoples during the pandemic. So the scope of the workshops as well widened to include all vaccines. Again, the vaccines was tailored to meet the local needs, and our delivery mode of the workshops was we delivered online and face-to-face workshops. The workshops contained information, as I mentioned, about all vaccines. We also had group discussions and Q&A during these workshops. The workshops also included an interactive exercise as well as role-playing and communication skills. The results, so we had over 70 participants, so these included community leaders as well as Aboriginal Medical Services and staff from the Hunter New England New South Wales Health, as well as non-Aboriginal community leaders. Some of the feedback from our workshops was high satisfaction with the workshop content and the format. It increased confidence and engaging in vaccine conversations, and it had a positive impact on community knowledge, especially up through the post-workshop yarns. And I've just added as well one of the comments that we received back from one of the webinars attendees. So I'll just leave that up there for you all to read for a little bit. Yep. So in conclusion, the workshop, it really highlighted the importance of culturally safe Aboriginal community-driven health education and addressing these public health needs. So it really empowerment through Aboriginal education and Aboriginal informed workshop was enabled to service providers and community members to really have that supportive engagement around vaccination conversation. The broader impact of this research, it really increased confidence amongst our Aboriginal and non-Indigenous participants, as I said, to really have that open and supportive conversation. It's also strengthened community engagement and collaboration around all vaccines, and it really highlighted the collaboration as a result of the workshops. And I just wanted to give a big shout out as well to our co-principal researcher, Miss Liz Harwood. So Liz has submitted a paper now and to a public for publication, and a training resource toolkit for health workers, and facilitating a conversation with Aboriginal and Torres Strait Islander people about vaccinations are in development. Now, my next research I'm going to be chatting about is the Vaccine Access and Acceptance Tool for Aboriginal and Torres Strait Islander families. The study the study focus is really to identify and understand relevant vaccine access and acceptance barriers for Aboriginal and Torres Strait Islander families. As we all know, it's really important to have a tool to measure the causes of under-vaccination in each communities. The vaccine barrier assessment tool has been developed by the Murdoch Children's Research Institute as to measure the two main barriers to really understand under-vaccinated for children under 5s in Australia. The tool was developed and validated through rigorous processes, including Australian parents with different cultural and social economic backgrounds and different levels of vaccine hesitancy. However, it did not involve or engage Aboriginal or Torres Strait Islander parents or caregivers. Therefore, the development of this of a culturally appropriate tool for Aboriginal and families and carers is a priority. So we've engaged with the Murdoch Institute as well as the Menzies Institute as well in Northern Territory. So we're engaging with the Northern Territory team and as well as our team here in Hunter New England to validate these tools within both those communities. So the aim was to work collaboratively with Aboriginal and Torres Strait Islander families and caregivers, really to modify and adapt the tool to ensure it's culturally relevant and easily to understand for our families. Adapting the tool will ensure the tool is effective in identifying vaccine barriers in communities, and the adaptation tool will be used to monitor our key drivers for under-vaccinated children in Aboriginal and Torres Strait Islander communities. Our participants, so we've interviewed 16 service providers, so that's people from representatives from government and Aboriginal community controlled health services, and we've also at the moment we've we've had 10 family focus groups. So that's in Northern Territory with the Northern Territory research team, as well as here in the Hunter New England research team. Early feedback from our service providers and families, they were really concerned about the vaccines and the safety of the vaccine and the effectiveness of the vaccine. Access issue is as well as likely for the cost of the appointment and the appointment availability. Hesitancy is not a big issue, but really it's the access and the logistic barriers is the really biggest concern. So that's getting to a AMS or a GP service to really get barbs immunised. The impact of the study, it's really to hope to inform and support and the development of a targeted strategy to address these barriers, as well as to promote the cost and effective solutions to improve the local childhood immunisation coverage and timeliness. And in conclusion, by validating and adapting the tool, the study aims to enhance the understanding of local vaccine barriers, as well as to support and development of strategies to increase the childhood uptake. And my final research project that I'm going to be chatting about is TIPS. This project was commenced prior to the COVID-19 pandemic, but the rollout was delayed. Some of you online this evening may have been involved in these meetings where the project findings were disseminated, but all things since COVID-19 has changed since the previous findings and the dissemination. So in July 2024, we reconvened the Tamworth Aboriginal Community Health Services and providers. So using a co-design workshop, we incorporated a World Cafe methodology, and the rollout of the 2024 TIPS program was really to focus on the solutions and to implement those solutions. So as I've highlighted previously in the two previous research that I've highlighted, there is no one size that fits all to our childhood immunisations. So that's why we've decided to reconvene the TIPS program. So TIPS was developed by the World Health Organization, and it uses data to identify the low pockets of the vaccination coverage. So for our tailoring immunisation program, we were looking at the Australian Immunisation Register, so that's and it's using a yarning technique as well to really understand the barriers to vaccination and what strategies are likely to be more effective. So it include co-design of a tailored approach with services, so health services as well as community partners. The yarning, so our research as well, this project is governed by Aboriginal researchers. It uses a culturally safe way of doing research, so it's research with us and not on us, and it involves Aboriginal facilitators in all of our group discussions as well as our interviews. Data is analysed as a group with an Aboriginal lens over it, and it takes a strength-based approach, so not focusing on the negative or the blame. At current, so as I mentioned, we reconvened the tailoring immunisation program, TIPS, in 2024, and it was really to develop and implement new immunisation strategies to improve for our 1-year-old Aboriginal and Torres Strait Islander bubbies in Tamworth. So based on our yarning workshop findings, our members include staff from the Population Health, Aboriginal Medical Service, Child and Family Health nurses, as well as staff from the primary health networks, as well as GPs and mainstream immunisation service providers within the Tamworth area. We currently have monthly meetings, and these monthly meetings are ongoing via the Teams. So these meetings, there really is to review our workshop results, and really we want to try and come up with a collective solution. So out of our yarning circles with our service providers and our community members, we came up with 3 themes. So the first theme was service providers' models are underpinned by a holistic family care option. So this really, what it's basically saying is ensuring a comprehensive care by facilitating coordination between service providers to increase immunisation. So really to promote the understanding of the roles of each service and our health services within the Tamworth area to really improve the immunisation delivery. And our second result was our service provider provides a welcoming environment. So this really says is like to create a further and develop a culturally appropriate service providing immunisation. So staff are trained and services foster a culturally safe environment where people feel safe, comfortable, accepted and confidence when they and confidence that they will be respected when they're making appointments and they're listened to. And our final result from the yarning circles was services implement accessible and flexible model of care for immunisation. So, and this is not the first time that we've heard throughout our research as well, is like our services just, if we could just do that flexible model of care for immunisation. So thinking outside the box, so having, offers hours after the 5 a.m. Close. I know, some of you will probably sit here thinking, it's hard, but that's what our families and our community members are actually asking. One of the great things that I know TAMS in Tamworth is actually doing is they're having every monthly on a Tuesday, they're having drop-ins, and they're not only taking their clients, but they're actually also taking other clients, other community members that are not clients of the Aboriginal Medical Services. So this is a really great initiative that was taken up by the Tamworth Aboriginal Medical Service. So if anyone's online, cheers to you guys. And again, I'd just like to acknowledge all and each and every one of you out there who without all your great work and, dedication to immunisation, our rates won't be as good as what they have been. So thank you. And I'd just like to give a big shout out to all of our research team. So from the VBAT, our Yarning About Vaccination and our TIP research team. So thank you. And now I'd just like to welcome Megan.
Thanks, Katrina. Thanks, everyone. My name is Megan Vidler and I'm a clinical nurse consultant in the communicable diseases team at the Population Health Unit. What is a communicable diseases team, you may ask? Because we're not very well known, but we're a team of doctors and nurses and epidemiologists and data scientists who analyse and track disease notifications throughout H&E. We monitor and try and stop the spread of diseases that can spread from human to human and animal to human. Many of these diseases that we track are vaccine-preventable diseases. So I'd like to say a big thank you to the Public Health Immunisation team, the PHN, and all the immunisation staff in the community listening tonight who play a major role in disease control by promoting, counselling people on and administering vaccines to protect our community and also making my job a little easier. We've got the respiratory update first of all. So New South Wales Health gives us a respiratory surveillance report, which tells us some really good news at the moment. Influenza is circulating at low levels. RSV is circulating at low levels. COVID-19 is at low levels, although it's rising. And all three viruses circulating at these low levels at the same time have been reported for a couple of months now, which is very rare. I think it hasn't really happened in my time at Public Health over the last few years, so it doesn't usually stay like this for very long. Pertussis is at higher levels and continues to increase, but we shall get to pertussis in a moment. But let's talk about COVID first, and please don't fall asleep. I think I can hear probably eyes rolling as we talk about COVID. I'm sure everyone is over it. But there's 3 graphs on the left-hand side here with indicators that is showing that COVID cases are continuing or beginning to rise. So let's have a look at the waves in these graphs. The top graph there is ED presentations and subsequent admissions to hospital. We can see spikes during past waves in January 23, which was ginormous, July 23, January 24, and again last winter. And remember, this is only COVID related. So in June and July, we also had high levels of influenza and RSV like we'd never seen before circulating, putting increased pressure on GPs, hospitals, and outbreaks in aged care facilities. And we are now beginning to see that little uptick at the end of the graph for October and November. The middle graph is the positive COVID test rate, and that is PCRs. Some people still do that. Again, this shows big numbers, January 23, January 24 and winter 24, and the numbers beginning to rise again in November 24. The bottom graph there is wastewater surveillance from Burwood Beach, and it's a great indicator of what's happening in the community. It shows spikes in January 24, winter, and again starting to uptick these months. So these graphs have been very good at proving what's happening over the last little while, and they're all pointing towards, unfortunately, what might be a new wave during Christmas again this year. The problem is when we have large numbers at a time of year when we're super social, we end up with very large numbers. So let's move on to the graph on the right, and it shows us sublineages and variants of COVID-19. So a subset of specimens from people who test positive for COVID via PCR at New South Wales Health Pathology Services undergo whole genome sequencing each week to identify and understand the behaviour of circulating variants. This sample may not necessarily reflect the distribution of all cases across New South Wales, as some people are using private labs, not all public samples are tested, but we do continue to monitor sublineages in samples from ICU as well to monitor increased disease severity. New South Wales monitors sublineages emerging globally and locally and considers their impact on the context for the local immunity profile. We continue to report the emergence of the variant XEC, which has been increasing globally. So from the graph we can see that JN.1 variant, the one in purple, which was the main circulating variant earlier this year, and now we see that dark peach colour increasing, which is XEC. You would definitely be forgiven for having lost track of the number of variants since we heard about COVID, but I suppose the important message at the moment is the main circulating variants of JN.1, the purple, KP.3, the peach, and XEC are all descendants in some way of Omicron. And I haven't said that word out loud for a long time, so forgive me, I just got the shivers. The KP.2 and KP.3 sublineages are sublineages of JN.1, and XEC is what we call recombinant. So it's because it's formed when 2 different variants affect a host at the same time, which allows viruses to switch genetic information, and then we get this emergence of a new variant with characteristics from both parents. So why is this important? Megan, why are you telling me this information? It's good news, because the good news is that the JN1 is a parent strain to KP.3 and XEC. So the new booster that will be available in Australia in about December will target and be effective against these current circulating variants. Although XEC remains a the minority variant globally, it appears to have a growth advantage over other circulating variants. We may not know why yet, but reports suggest that it's able to spread more easily than other variants. So we encourage you to continue to review the booster guidelines and offer a COVID booster to all patients that are eligible. While we always expect waves of pertussis every few years, this year has definitely been a bumper. We thank you for everything you're doing to continue to protect our most vulnerable in the community. Both of these graphs show us trends in pertussis from 2009. We can clearly see that every few years we have a spike in numbers. This is a normal pattern driven by waning immunity over time due to lack of exposure to circulating infection, and immunity from vaccination also wanes. The graph on the left is New South Wales, and the graph on the right with the green and blue is H&E and Central Coast LHDs, and we can see similar patterns. We see a high year in the state and in H&E and the Central Coast for 2015. PCRs became readily available for testing in 2012, and this spike may be a result of more testing at that time. We see another peak in 2018, and then of course we see the public health measures of isolation, social distancing and hand hygiene, we remember those, right, having a similar effect on all respiratory viruses in 2020 to 2022. Although I'd have to admit that maybe some of this small number of cases was lack of testing as well. So why the jump this year? I hope you can see the jump in that slide at the end there. Mine's just missing off the page. It's probably a multitude of factors. So is it a combination that we just didn't have that little wave that we were expecting during the pandemic years? And is this two little waves in one big wave this year? Have we missed out on some vaccinations, older children with waning immunity, and missed or delayed boosters due to isolation during COVID? Is it vaccine fatigue from parents and grandparents missing boosters? Fewer pregnant women being vaccinated during the pandemic? Or did we miss a lot of cases at the beginning of this surge because symptoms were not traditional symptoms? We hadn't seen pertussis for quite some time, and sometimes we're not seeing those traditional big coughs from little kids. And therefore pertussis spread, and we lost a little bit of control by people not isolating while infectious at the beginning of this wave. Things to think about. You can see that this graph, you can see the really fast increase in cases for the 5 to 14 age range, that greenish colour. And you can see that when this happens, we see a rise in cases from the 0 to 4 age group as well, the orange colour. And this is community spread across age cohorts, siblings bringing it into houses with younger children. We see this daily with our monitoring of lab notifications. 1 week we'll have a large group of primary school aged children, and then a couple of weeks later we'll be overwhelmed with preschool aged cases. So what can everyone do? The best protection against whooping cough is vaccination. You all know that. The greatest percentage of hospitalised cases for infants under 6 months. I've seen some unpublished data I can't show you, but apparently I'm allowed to talk about it, so I will, where there's 43% of hospitalised cases under 5 were not fully up to date with their vaccination. Pregnant women should be vaccinated between 20 and 32 weeks of every pregnancy, no matter how close together their pregnancies are. Maternal vaccination is the key element in protecting infants. The same unpublished data, only 40% of mothers of hospitalised cases who were under the age of 6 months were recorded as vaccinated during their pregnancy. A booster is also recommended for adults aged 50 and 65 years and child and healthcare workers every 10 years. Please remember that the symptoms may be mild for children that are vaccinated. We ask parents to stay at home while awaiting results. We're seeing a lot of children returning to daycare because their parents don't think it's pertussis while waiting for their results, or they think they're no longer infectious. Children should stay at home from childcare and primary school for 21 days after the onset of cough, or until they've received 5 days of appropriate antibiotic treatment. So please consider testing pertussis in all people who present with a compatible illness. Sometimes vaccinated people do not present with the classical symptoms, and therefore it's important to retain a high clinical suspicion of pertussis. So we get a lot of calls regarding who's deemed a high risk contact of cases and who needs prophylactic antibiotics as a contact. And we love talking to you, so please always reach out if you'd like to talk things through. You can also find the control guidelines for pertussis. There will be a link in the slides, but you can also search New South Wales Health Control Guidelines. The main aim is always to protect our youngest patients. Again, from my unpublished data source, the proportion of cases hospitalised increases as age decreases. So if we look at all cases of pertussis, 0 to 100 years, only 1% of the total case numbers require hospitalisation. But of all the cases under 6 months of age, 40% of those required admission to hospital. And this shows how serious pertussis still is in young infants. So high-risk contacts are infants under the age of 6 months and people that may transmit pertussis to them. In the event of a household exposure setting, high-risk contacts include expectant parents or carers in their last month of pregnancy, and all household members where there is an infant under 6 months present. For example, if the case is 5 years old but lives in a house with a sibling or a relative who is under the age of 6 months, then the whole household should have antibiotics regardless of vaccination status. Another example is that if there's a case in a house and there is a woman in her last month of pregnancy, so a chance of giving birth while infectious, especially as the virus moves around from person to person in the household, then the whole household should receive antibiotics regardless of vaccination status. And of course, in any setting, close contacts of a case who are considered high-risk contacts include healthcare workers working in maternity wards or newborn nurseries, where there are women in their last month of pregnancy or infants under 6 months, childcare staff who look after infants aged 6 months, under 6 months, and children who have close contact in childcare with children under the age of 6 months. The Public Health Unit interviews parents of all cases under 5 to assess whether their cases have been to childcare during their infectious period. There are different recommendations for contacts in childcare depending on the number of cases and if there are any children who also attend care who are under 6 months of age and therefore have not had 3 doses of vaccine. And of course, again, women in their last month of pregnancy. Management of immunodeficient contacts should be made on a case-by-case basis. So let's never forget about measles, a timely reminder this week after a notification of a case in Sydney. And the good old saying, measles anywhere is a threat everywhere. People travel, we love it. People take their babies when they travel. Fair enough, they're allowed to do it. And then they return home to Australia. So we can see on this slide, we can see 2 figures of where the most cases of measles have been in the last 6 months and are at the moment. The good news is that we haven't seen those numbers like we saw in 2019 and that we were really expecting when borders reopened after the pandemic. But please note there are a lot of cases in places where Australians love to travel, whether it's going back to visit family or travelling to our neighbours in Southeast Asia. The graph on the right shows cases currently in Southeast Asia. I think the last lot is October. So if you haven't read the latest media release on the case in Sydney, please have a look at it. The case is likely acquired measles in Malaysia, but the exposure period does extend to the time that they were back in Australia. So please have an even higher index of suspicion over the next month of measles in people with a compatible illness, even without a history of overseas travel, and especially if they're unvaccinated. Measles remains endemic in many parts of the world, including destinations popular with Australian travellers. So just remember that high index of suspicious in people that have a clinical compatible illness. And consider measles in patients that have a fever, a cough, a runny nose, conjunctivitis, followed by a rash. A rash typically begins on the face and neck and then becomes more generalised, and the fever is usually still present at the onset of the rash. So please remember when you're testing to isolate in a single room and add respiratory precautions, and please ask people to isolate at home while they're waiting for their results. Please give us a call at the Public Health Unit. We would love to have a chat with you. Happy to chat through anything that you like about testing and isolation, but we'd really love a head start on perhaps where there may be a case in our local area. And the basic rule is to collect a nose and throat swab, a first pass urine sample, and then blood for measles serology. Please have a look at the testing guidelines if the rash has been present for more than 3 weeks. and a full respiratory panel may give you an alternate diagnosis if the measles is negative. So children under the age of 12 months can have a dose of MMR from 6 months if they are travelling to areas with a high risk of measles. This will be MMR dose 0, and they will still need to have another 2 doses. They should receive the next dose at 12 months of age or 4 weeks after the first dose, whichever is latter. And the second dose to be given at 18 months of age. And for people who are unsure if they've had 2 doses, should get a vaccine, as additional doses are safe. And this is particularly important prior to travel. The next thing that I'd like to talk to you about is Mpox. So we can see 2 graphs on the left-hand side here, and they can both be found on the New South Wales Mpox Surveillance Report, which is updated weekly. And we can see from the top graph, levels peaked in September 2024 and have remained at high levels since. Almost all cases were assigned male at birth and report male-to-male sexual exposure. 90% of cases were infected in New South Wales, the largest percentages in Sydney and South East Sydney. There have been cases in Australia in females, and heterosexual transmission has been reported. All cases in Australia have been clade 2B, and there still remains a risk of the importation of the potentially more serious strain of clade 1B from Africa. So if Mpox is suspected in a returned traveller or has someone who has contact with a returned traveller from Africa, please give us a call immediately. It's really, and this is really another timely update, as a few days ago America reported its first case of clade 1 Mpox in a returned traveller from Africa. So please have a low threshold for testing symptomatic people, and symptoms can be quite mild: a sore throat, pimple-like lesions, anywhere on the body, including the face. Mpox can mimic other conditions like herpes and tonsillitis. Test all sexually active people with compatible symptoms, regardless of sexual orientation, vaccination status, or travel history. If you're testing for herpes, please test for Mpox. And please remain aware of the possibility of Mpox infection in any patient. From the chart on the right-hand side, you can see that 46% of cases in New South Wales have been in unvaccinated people. Mpox vaccination is a 2-dose schedule and is recommended for groups at risk of exposure to Mpox, which includes gay, bisexual, and other men who have sex with men, sex workers, and people living with HIV. Please be alert of the possibility of atypical and attenuated presentations in people who are fully or partially vaccinated. Some patients have had multiple presentations to healthcare prior to diagnosis due to mild symptoms. Mpox cases in H&E are referred to the sexual health clinic when they are the experts in this area. After hours Mpox contact interviews are completed by the PHU staff and risk assessed in conjunction with the ID team at the John Hunter Hospital. If you need any help with testing or vaccination or require any information on Mpox or other STIs, consider SHIL, the Sexual Health Info Link line. SHIL is a wonderful service and can help with information on Mpox and vaccination, referral and bookings for Mpox vaccination, information referrals and support for HIV, hepatitis and STIs, and support with complex partner notification. And it helps staff, GPs, nurses and allied healthcare workers with clinical advice on the management of Mpox, STIs and bloodborne viruses, and can be good for referrals and clinical support and up-to-date testing and treatment guidelines. High-risk close contacts of Mpox cases may include sexual contacts, household cases or healthcare workers. If indicated, post-exposure preventative vaccination should be given as soon as possible after the first exposure to a confirmed Mpox case. Vaccination within 4 days of the first exposure to an infectious case will provide the highest likelihood of disease prevention. Vaccination between 4 and 14 days after exposure is likely to attenuate the disease. Post-exposure preventative vaccination during pregnancy may be considered after a risk-benefit assessment. Safety data for the use in pregnancy are limited, but no concerns have been identified to date. Any decision on the use of a vaccine should take into account the likelihood of Mpox in the pregnancy and the risk to both mother and fetus. We've recently recommended vaccination for 2 pregnant contacts in H&E. Where post-exposure preventative vaccination is indicated for a child, off-label use of the Mpox vaccination is possible. Mpox vaccine can be used in children where the benefits of vaccination outweigh the potential risks, and we have offered vaccination to a close contact child, but the parents declined. The Shield service is a fantastic resource for all Mpox and other ST advice. This is my last slide about disease, and it's good old gastro. So gastroenteritis in the community is continuing to increase in recent weeks across the state, mainly driven by rotavirus and norovirus. And of course, we know rotavirus can be particularly severe in young children. And norovirus is a really common cause in outbreaks of residential aged care facilities and childcare centres. So if you do have people in your clinic and they've come in with gastro and it is possible to get a sample, it's really helpful for childcare centres and aged care facilities to know what they're dealing with. And of course, we can vaccinate against rotavirus. And that's it from me. Lots of bad news from the CD team. Yes, I want everyone to go and collect samples of stool specimens. Thank you. There's some useful links there. Thank you very much, everyone. Thanks for having me.
Hello everyone, my name's Kylie and I'm from the H&E Kids Immunisation Service. So tonight I'm just going to give you a little overview on the H&E Kids Immunisation Service, how to refer to us and our approach to increasing vaccine rates through opportunistic immunisation, and a few tips and tricks you might like to think about at your practice. We're a small team. We've got our medical staff is Professor Rani Bhatia, who's our immunologist, Dr. Cohen Butters, who's our infectious disease consultant, myself, and then we have two admin support and clinical coordinators, Chloe and Fatima. We're located at John Hunter Children's Hospital on level 2 in the paediatric outpatient department. So the H&E Kids Immunisation Service is a Ministry of Health funded service. We offer complex immunisation service to children and young people across Hunter New England Health. Our team offers a drop-in service for NIP patients. We also offer special risk groups, including our annual influenza vaccine program, catch-up schedules, immunisation after adverse events, discussion and advice for children and young people and their parents concerned about vaccines and vaccine safety, specialist immunisation advice, so that's generally for our high-risk groups, respiratory, cardiac patients, oncology patients and post-transplant. We have a BCG clinic which also incorporates basic travel advice. We provide education to John Hunter Children's Hospital and outreach, and we also collaborate with Population Health. So the immunisation service provides care across multiple areas of John Hunter Children's Hospital. We cover the paediatric outpatient department, so that's every patient coming into the hospital for a paediatric appointment. The 4 inpatient wards, so H1, J1, J2 and Nexus. The paediatric oncology day unit, ICU and emergency. We offer immunisations during scheduled procedures in theatre, and we also provide support across other areas of Hunter New England. So we take a proactive approach to the NIP and provide opportunity in immunisations. Every interaction we have with a family is an opportunity. So our outpatients and inpatient air records are checked daily to obtain immunisation status. This is roughly about 200 patients a day. We take an individual focused approach, recognising that every patient's history is unique and influenced by various factors. Their immunisation needs can vary, so we tailor our approach to the NIP to suit each person's specific requirements. Generally, we have 4 types of families that fit into a category. Conscious objectors, vaccine hesitant families, families who are unaware that their children have outstanding immunisations. And then we have the families that are aware immunisations are outstanding, but due to life's challenges, whether that be access to services, costs, travel, or the chaos of life, have been unable to maintain up-to-date status. Our focus is providing care to the under-immunised children. So we do see in our clinic hesitant parents who often get mistaken as parents who have decided to decline vaccines completely. They often have serious or complex questions. Our goal at each consultation with these parents is to listen, to increase vaccine confidence, and to vaccinate within the parameters of which a family feels comfortable. This will look very different for every family. A delayed schedule involving splitting antigens is an option for families concerned about the number of vaccines their child is receiving. While this approach requires more injections and an extended vaccination time, it can address specific family concerns. It's important to accommodate the unique needs of each family. If your practice is not comfortable or confident in managing a delayed schedule, please refer the family to our service. Although you are in the perfect position, you have a relationship with these families, they trust you, and it's an ideal opportunity for them to delay a schedule if necessary. It does take a little more time and a lot more effort, but it's all worth it in the end. We have a patient which I have seen every month to 2 months for the last 12 months. His first immunisation was done at 6 weeks of age, and we have split every antigen for his family. So his grandparents were objectors, and his mum vaccinated herself as an adult and is very hesitant when it comes to giving all antigens at once. So we have split it over a very long period of time, but he is currently over 12 months of age and up to date, and he's coming in next week for his 18-month immunisations. So it is possible, but it does just take time and planning. So I'm sure you all know about the Australian Immunisation Register, the AIR. It's a national register that records all vaccines given to all people in Australia. So it's a vital tool that we use as providers to assess a person's vaccination history and plan vaccination needs. It's therefore vital that these records are correct and up to date. So since February 2021, recording on the AIR became mandatory. All administered immunisations are to be reported within 24 hours and no later than 10 working days after vaccination. So most practice software automatically uploads administered vaccines to the AIR. However, there are some cases where the uploads may fail, such as when the patient does not have Medicare. In these cases, it's essential to ensure a record is created and that the administered immunisations are manually uploaded. So these records can be merged at a later date when there is a Medicare record. It is very, very important that this happens, especially for the 6-week immunisations for little babies. We've recently had a little one who was from a chaotic family and had their 6-week immunisations, then was placed into care. So there was no AIR record created and the immunisations that were administered weren't recorded. This baby was vaccinated, again in error. The schools program. So teenagers can be a challenging demographic, making them particularly vulnerable and emphasising the need for extra care and support. So immunisations are scheduled in Year 7 and Year 10 students and are typically delivered through the schools program. However, a significant number of children in this age group have missed. We do see a lot in this age group come into the hospital. So some of the common reasons that these immunisations are missed are homeschooled children that are not part of the school program, students who are hesitant to receive vaccines at school without their parents, parents that consent for their child to receive vaccines at school, but the child declines, and the parents then are unaware that the immunisations weren't administered and assume the child's up to date. So it's essential to be proactive in checking the air records of the children in this age group and administer any required immunisations to ensure they are fully protected. Behavioural issues can also come into play in this age group, where they're unsafe to be vaccinated in the school environment. So being with their regular GP in an environment that they're comfortable with is an ideal opportunity to make sure that these immunisations are delivered. So vaccinating our special risk groups. Some patients are at high risk of childhood disease and may require additional doses of certain vaccines to ensure optimal protection. These extra immunisations are often overlooked, because they're not included on the NIP, and they're crucial in protecting vulnerable individuals. Reviewing the patient's medical conditions can help identify if they belong to any of these special risk groups and require additional immunisations. Some examples of these groups would be premature infants, so those born less than 28 weeks have an additional Prevnar 13 at 6 months, Pneumovax 23 at 4 years and then 5 years after, and those born less than 32 weeks receive an additional dose of hepatitis B at 12 months. So our Indigenous patients, Bactero, so the meningococcal B for infants under the age of 2, hepatitis A, hepatitis B, Prevnar and Pneumovax 23. Other patients to consider are respiratory conditions, so patients with cystic fibrosis, they receive an additional Prevnar 13 and Pneumovax 23, as well as a second dose of varicella. Patients travelling to high-risk countries, so hepatitis A, typhoid, MMR if they're between the age of 6 months and 12 months, and also a referral to our service for our BCG vaccine. Those people who are immunocompromised, and this is based on their medical conditions. If you have any questions regarding specialist high-risk groups, please feel free to contact our clinic if you need support. We work closely with GPs and are more than happy to provide support. We have recently had a cystic fibrosis patient who was hesitant to receive anything in a hospital setting, was very comfortable with their GP. We've worked very closely with this GP practice, and they have administered or required additional immunisations, as well as currently a patient who's about to have their spleen removed. So they are required to receive additional immunisations prior to having their spleen removed. So we've provided support and on which vaccines they're needing and in which time frame they are from Tamworth, so that logistically is a long way for them to travel to Newcastle. So we're more than happy to provide support or any advice that you need on these areas. The flu vaccine. So everyone knows that the flu is a common disease of the respiratory tract, and influenza is the most common vaccine preventable disease in Australia. So although it can be a mild disease, it can cause very serious illness in otherwise healthy people. It affects people of all ages and require hospitalisation and cause death. So the annual influenza vaccination is recommended for everyone over the age of 6 months. Many of the people that we see are open to receiving the flu vaccine when offered the opportunity, even if they wouldn't actively seek it out on their own. Offering the vaccine during an appointment provides the perfect opportunity to increase uptake and protect more individuals. So the flu is around always. It does peak during winter, but can attack at any time of year. So it's never too late for a flu vax. Adverse events after vaccination sometimes occur. It doesn't necessarily have any relationship to the vaccine. So serious adverse events following immunisations or APHIs are extremely rare, but any reaction, whether mild or serious, should be reported to your population health unit. Even a mild reaction to a vaccine can significantly influence a family's decision to receive immunisations in the future. If a family expresses concerns about post-immunisation reaction, becomes hesitant, please refer them to our service for support and guidance. We do have an adverse events clinic that is run by our immunologist, Dr. Rani Bhatia, who's more than happy to see any family who have any worries post-immunisation. We have had families declining immunisations due to mild redness at the site or a temperature, all of which are known side effects from a vaccine but can be very traumatic for a family. We've had a little girl who had apneas post her birth immunisations and then again at her 6-week immunisations. She's come into the clinic, had a consult with Dr. Bhatia, and we have executed a plan. She had her 4-month immunisations done over 3 sessions. So the first one was the oral Roderick's, then she came into the ward and had observation for 6 hours post her Prevnar and Vaxelis, which went ahead perfectly, then came back into just a clinic setting for her Bexzero, all without any complications at all. And now her family is comfortable in receiving all future vaccines with her GP. So it can lead to a family choosing to decline vaccines in the future, but the conversations are very important to have. So how to refer to our service? You can refer through the health pathways, through a referral form on the HNE Kids website. There's also a self-referral for BCG vaccines, as well as our contact phone number. Thank you so much.
Thank you so much. Some really great information so far. So please stay with us. Please come back. We would love to have you. As you can see on your screen, it's time for our 10-minute break. So go have a break, bathroom break, wine break, cup of tea break, just a rest, and we'll see you in 10 minutes. Thank you.
So welcome back, everyone. I hope you managed to refresh your teapot, go to the loo, and you're back comfortable. So we've got some lots of interesting information yet to come. And I guess the most exciting information that we've got tonight, and I'm not just saying that because I'm presenting it, but it's actually RSV 2025. So you've had some fabulous information up until now. So now we're getting into things that you all really want to know about, because you've been seeing it with the media release and we've been anticipating this program and some details. I will say a disclaimer before we start, and you're going to have lots of questions about this program. We have some questions, so what we really want you to do is pop all your questions into Slido that you might have about RSV 2025. We might not be able to answer them tonight, but they're going to guide how we proceed and give you information as this program gets rolled out. So you will have seen the media releases and the ABC News sprouting that we're going to offer free RSV vaccination, okay, to mums and to bubs in early 2025, ahead of our RSV season in 2025. It was rolled out a bit piecemeal this year, but we're going whole hog next year. We got this question a lot, and I thought I'd just go through it with everybody because we have a vaccine now and we have our monoclonal antibodies. So the biggest question is the RSV monoclonal antibody a vaccine? And the short answer is no. It's not a vaccine, but it works to prevent infection by a process called passive immunisation. So with passive immunisation, the antibody is given to somebody, so the person's own immune system is not generating that immunity. So the passive immunity is effective for a short time, and the quantity of the antibodies will decrease over time, but the person is protected for that short term, which is what we're aiming for. And in this case, we're providing passive immunisation through two methods, by vaccinating mum and by offering nirsevimab. So when we talk about active immunisation, that's when a vaccine is given, and then the person's own immune system is then making a response to that infection. So when they encounter that infection in the future, their immune system's ready to fight it, whereas with passive immunisation, they will remain susceptible again after that passive immunisation wears off. So what is our program going to look like next year? It's going to be a hybrid program. So we're going to be offering a maternal vaccination, so RSV vaccination, and Abrysvo is going to be the vaccine that's funded by the NIP, and it's going to be offered to pregnant women at 28 to 36 weeks. And hopefully that's going to roll out around the 3rd of February 2025, let's say 3rd, 10th, somewhere around there that's going to roll out. And then come along March, we're going to be offering nirsevimab, so our monoclonal antibody, okay, to certain infants. And there's going to be some eligibility criteria that we're going to go through, and that is funded by New South Wales Health. So Abrysvo, the vaccine that we're going to be offering, there's some recommendations in the handbook, and we just need to be really familiar with those. So it's a single dose recommended for all pregnant women at 28 to 36 weeks gestation. It's not yet recommended for use earlier than 28 weeks. There's still some waiting on additional safety and efficacy data. It can be given past 36 weeks, but that infant may require nirsevimab, and that's because if Bubby's born less than 2 weeks after mum has had that vaccine, she may not well have developed those antibodies to pass on through Bubby. And Abrysvo is the only RSV vaccine approved for use in pregnant women. Okay, just remember we have Arexvy on the market at the moment, which is another RSV vaccine, and it's registered for use in adults 60 years and over on private script, and it's not to be given to pregnant women. This is going to be a year-round program, and like we said, routinely offer it at your 28-week antenatal appointment, just to make sure we don't miss anyone. So you're going to have some women that are already pregnant when that vaccine program starts. So if they're already more than 28 weeks pregnant when that commences, then please offer the vaccine ASAP. It can be safely co-administered with your DTPA, influenza and COVID vaccines that are already recommended in pregnancy. And I guess you could probably anticipate maybe some more conversations that you're going to have with pregnant mums. This is our 4th antenatal vaccine that we're introducing, and we're introducing it just before influenza season. So there's going to be a lot of vaccines that are due for these mums. So be thinking now about how you're going to have those conversations, and maybe even start those conversations with women who are already pregnant and are coming in, that this is going to come up in February. It's a single IM injection in the deltoid, and it requires reconstitution. Don't we love reconstitution? I guess the warning there is, remember that it requires reconstitution. So nirsevimab, so Beyfortus is the brand name. There's 3 levels of eligibility. Okay, and we're going to go through them in more detail now. So just bear with us as we go through that. There will be more resources available as the program, or hopefully before the program is rolled out, so details will be clearer for you. So nirsevimab for newborn infants. So it will be available in public and private facilities to babies born to mothers who did not receive RSV vaccine during their pregnancy, or they're born within 2 weeks of the mother receiving their RSV vaccine. Once again, that's because mum hasn't had the chance to make those antibodies. For babies who are born with risk conditions of severe RSV disease, or to mum with severe immunosuppression regardless of maternal vaccination, because mum may not have sufficiently developed those antibodies if she's severely immunosuppressed. And to mothers, to babies whose mothers have received RSV vaccine in pregnancy but have subsequently undergone a treatment such as cardiopulmonary bypass that has led to the loss of maternal vaccinations. And once again, there will be a decision aid that's created to help you work through this. So they're for newborns. There's 2 other eligibilities, and this one is for infants up to the age of 24 months, but who remain vulnerable to severe RSV disease through their second RSV season. So these are babies born from the 31st of October 2023, last year when it first rolled out, to the eligibility to the 31st of October this year, without any known prior RSV infection, but with risk conditions for severe RSV. And the handbook really outlines those risk conditions, as you can see there. Preterm birth, less than 32 weeks. Hemodynamically significant congenital heart disease, significant immunosuppression, chronic lung disease, neurological conditions that impair respiratory function, cystic fibrosis, and trisomy 21, or other genetic conditions. So you're going to have to be really clear on those conditions associated with increased risk of severe RSV disease. And remember, it's only eligible for those children. The third category is a little bit of an expansion with just in New South Wales. So they're going to try and capture the babies. So that last one was ended at the babies born on the 31st of October 24. NSW in New South Wales are extending that from 1st of October to mid-March 2025. So these are babies that were not protected through maternal vaccination and didn't receive nirsevimab at birth, okay, because it wasn't around. Infants without known prior RSV infection and have the following risk conditions for severe RSV. So preemie babies born less than 37 weeks, all Aboriginal and Torres Strait Islander infants, can't stress that enough, and other conditions associated with increased risk of severe RSV disease that we talked about in the previous slide. Once again, they're going to have a decision aid on that as well. So these decision aids will be crucial for you guys to have so that you can figure out who's eligible and make sure that we don't miss any of these really vulnerable babies. Hopefully, maternal vaccination will cover most. So how do we administer and present it? So it comes in 2 dosages, a 50 milligram and 100 milligram. Okay, so our babies entering their first RSV season, okay, and they're under 5 kilos, get their 50 milligram. If they're 5 kilos and greater, they get their 100 milligram. And you can use 2 of the 50 milligrams if you don't have any hundreds. But for babies entering their second RSV season, the recommendation is for 200 milligrams. Okay, and if you're giving 2 injections, you just need to make sure that you're giving them in different injection sites. So who can initiate RSV immunisations? So it's actually been added to our authority. So any authorised nurse and midwife can independently administer Abrysvo and nirsevimab. So it's been there on our authority, which is absolutely wonderful. And it remains the same, that if a registered nurse or a midwife and enrolled nurses who are not authorised can administer them, but they have to have a medication order from a medical practitioner or a nurse practitioner. And they must be available for supervision or advice if required. So that remains unchanged as with any other vaccines. So who can get the RSV vaccines? So Abrysvo is going to be available for pregnant women from all antenatal care providers. Okay, so that's going to be your GPs, your AMS, or primary care providers who are providing antenatal care. So that's really exciting news because it was so limited. Nirsevimab was really limited this year. Nirsevimab doses for infants at birth will be available in private and public health facilities, and there will be opportunity for those who didn't get it at birth to actually access that vaccine after discharge from hospital as well. The monoclonal antibody. And nirsevimab for older infants will be available from private public health facilities, GPs, Aboriginal medical services. Okay, how to access them will be rather strategic. So how do we order our RSV immunisations? So Abrysvo and nirsevimab will be able to be ordered from the New South Wales Vaccine Centre, which is really great because this year we couldn't get nirsevimab, which is not a vaccine, from the vaccine centre, but that's changed and that will be available. In a New South Wales health facility though, the clinicians should just liaise with their local pharmacy department regarding supply and they will do all of your ordering. For nirsevimab for older infants though, so the Abrysvo and the nirsevimab on the left is just for the ones within hospital and obviously antenatal and just newborns, but for older infants, it's a little bit more complex. The babies have to meet the criteria and then you're going to have to fill out a nirsevimab order form, okay, for GPs and AMSs via the New South Wales Vaccine Centre webpage. So there'll be a form that you have to fill out. There'll be one form per eligible patient to be completed. So if you have 20 babies that you think are eligible for this monoclonal antibody, you're going to need to fill out a separate form for each of those children. And they're suggesting that so you're not ordering one immunisation at a time, that you consider your eligible cohorts before placing orders. Obviously that's not restrictive, okay? So if you only have a few that you know of and next week you know more, the good news is all your nirsevimab orders placed by GPs and AMSs will not count towards your monthly supply limit. So at the moment you're limited to 2 orders from the vaccine centre per month. These won't count towards those 2 orders. So that frees you up significantly in you don't have to know all your patients that you think you're going to need nirsevimab. There's going to be a lot of resources out there. There's slowly developing resources for pregnant women. At the moment, the vaccinations before, during and after pregnancy, the New South Wales Health webpage has actually been updated slightly and it does include RSV vaccine down there. It just takes you through to the handbook. But they will develop disease fact sheets. Maternal webpage will be updated. There'll be a maternal prevention program fact sheet. There'll be FAQs. There'll be a video for pregnant women and resources for Aboriginal people as well. There's an important vaccines in pregnancy flyer at the moment, or brochure, and that's in the process of being updated, which is really handy. So it'll be great if these resources are out well and truly before the program starts. There'll also be some clinician resources. So a clinician's guide, decision aids. Those decision aids will be really, really important. So when you get those, make sure you've got them laminated and up clearly so that everyone has access to them. Eligibility information, FAQs and program-specific FAQs. The webinar will be recorded and the handbook is in the process of being updated. So hopefully there'll be loads and loads of resources out that you'll be able to familiarise yourself with prior to the program rolling out. But it's a very exciting program and we've seen results from overseas and even other states in Australia that have introduced widespread RSV vaccination and nirsevimab rollout, and the reduction in RSV cases in hospitals and admissions is just phenomenal. So we're hoping to replicate that in New South Wales. Once again, I know you've probably got lots of questions, as do we, but we want you to pop them into Slido, and if you don't make it to popping them into Slido, can you please just email them to us, okay, at our HNE LHD-PH immunisation at health.nsw.gov.au web email address, and we'll love to collate all of those, and hopefully we can make it to the point with lots of answers in there and resources for you. So more information to come as we get it. But it's a very exciting program to have roll out. So that leads me to something a little bit different. So the immunocompromised and vaccines, it's a very complex part of the world, isn't it, of vaccinations. Just a little bit of a case story. We had a 38-year-old female. She passed away with a picture of rapidly progressing respiratory failure. Her post-mortem showed widespread bronchopneumonia in all lobes of both lungs. And of course, her cause of death was bronchopneumonia. During the investigation, obviously they look up vaccination history. This woman was unvaccinated against pneumococcus. Okay, so that is pretty awful. When we look at her patient history included trisomy 21, a past history of bronchiectasis, and she resided in a care facility. To the seasoned immuniser, they should have been 3 red flags as to we need to look at pneumococcal vaccination recommendations for this patient. So it's a really sad case, but I think it's a real highlighter in how important it is to be looking at people's past history and their current health state, and be looking at all those factors, risk factors, and recommending vaccines that they're due to keep them well and healthy. It is complex, okay? Vaccinating people who are immunocomplex is really complex, but they have an increased risk of morbidity and mortality from many vaccine-preventable diseases. The handbook has lots of information and lots of guidelines on what to do and how to work out which vaccines are due for our immunocompromised people. Of course, you're going to have to assess the extent of their immunocompromise. We get a lot of questions about that. We get a lot of people ringing in and saying, you know, is this considered immunocompromised or what? We suggest that if you are really unsure, you need to be contacting their specialist and seeking advice from them about what the specialist is saying about their immunocompromise. But we know that it can be challenging, and we need to review their immunisation history, develop a vaccination plan, because they may have reduced protection from previous vaccination, reduced response to vaccines, so they might need extra doses, an increased risk of vaccine-preventable diseases or complication, and an increased risk of adverse events, particularly from live vaccines. So we know that immunocompromised, we don't give our live vaccines. So we need to be really careful. There's lots of charts, and NCs have got some great stuff. The handbook have got some really good resources. But in the end, feel free to call us. We're happy to have a chat about immunocompromise. And I have one more topic before we hand over to Kirsty. Preventable vaccine administration errors. Now, this is not a session about having a go at anyone or dobbing anyone in. This is something that we can actually prevent. So we know that our children are receiving a lot of vaccines, okay? So up to 18 or more scheduled vaccines before their 18th birthday. So the opportunities for vaccine-related areas are really great, okay? So we also got adult vaccines, optional vaccines, travel vaccines. A lot of them sound the same. There's different brands for each different antigens, so it can get really complex. So it's really easy to make a mistake if we ignore some simple guidelines that we have. So if we select an incorrect age-specific formulation of a vaccine. Okay, so when is Hep B paediatric or adult? When is Hep A? They're different. If you're unfamiliar with the dosing and the schedule and the age specification or the route of a vaccine, you fail to check the patient's age or the vaccines they've already used, you're confused by similar vaccine names and abbreviations, or you store similar looking vaccines close to one another in those baskets that we all have in our fridge. Nothing beats looking at a vaccine. So just an example of some of the vaccine errors that we've had in the last couple of months. So we've had Shingrix administered to a 10-month-old instead of influenza. That's a pretty big one. Inadequate gaps between live vaccines. We had a whole dose, a whole vial of COVID vaccines administered, so that's equivalent to 6 doses. Infanrix and Vaxelis administered at the same visit. Third dose of Shingrix administered. We've had piles of third dose of Shingrix administered. Varavax instead of Prevnar 13, 2 doses of Vaxelis, so same vaccine given at the same dose. 12-month vaccines repeated again at 18 months. Bexsero instead of Nimenrix. Expired vaccines administered. And the old unreconstituted vaccine, so Shingrix administered. So all of these are unavoidable. So what can we do to avoid these common errors? We can check and know our immunisation schedule. So that's really important. Be familiar with the immunisation schedule. Check your patient's history. Check AIR, check your practice software, check Blue Books. There's lots of different records. There's no one source of truth about a patient's immunisation history. Check that vial 3 times. When you get it out of the fridge, when you're drawing it up, when you're putting a needle on it, when you're popping it in an arm. Know your minimum gaps. Prepare vaccines for one patient at a time. So you've got a whole family in there. Don't get them all out at all at one time. Check that you're using the correct diluent. Actually, it should be just correct that you're actually reconstituting a vaccine. Check the expiry date and confirm the correct vaccination site. What are you going to do if you make an error? Record the details accurately in the patient's clinical notes and call us. Okay, we're happy to talk you through it. We're not going to rouse on you. We're happy to talk you through it and identify how this error has occurred, what can we do for the patient, and what steps you need to do most. We've had nurses call us in tears, and we're here to help and support. So really important, it's open disclosure with the patients and the parents. Okay, be honest about what's happened and do that in a really timely manner. Then you have to reassure the patient or the parents, review the incident, okay, amongst your team and identify how this error has occurred. And when you're doing that, you need to decide how are you going to actually avoid that happening again. Then you need to discuss the outcome of that review and make the changes to your processes. Keep in touch with the patient or the parents of that patient over the next week or so, just to make sure, just to reassure them that you acknowledge that you've made an error, that you care for them and that you're there looking after them. And then what we like to do is we like you to complete an AFI form during the RegCap link on our webpage. That way we just keep a record of not you making an error, but just the errors. And that way we can actually collect safety data. So all of this leads to collecting, this has accidentally occurred. We're now following up on that and we can see whether or not anything's happened from that error. So it really goes to expanding our safety data that we collect on vaccines, which is ongoing all the time. So there's our link. It's a lovely RegCap survey. So we know that vaccines are safe and well tolerated, but we also know that when errors occur, they can actually undermine confidence in vaccines. They also require patients to return for further vaccines. That makes parents and patients really unhappy, and it creates a lack of trust in providers. So when we know that our vaccination rates are dwindling, and we know the reasons for that is really complex. Some people will say it's just COVID that's made people unhappy with vaccines, but we know that it far extends beyond that. It is not just vaccine hesitancy. There's a very complex reasons in there. So the last thing we need to do is be giving people reasons to create a lack of trust or confidence in our vaccines. So keep vaccinating and keep chatting with us, and I'm handing over to Kirsty.
Good evening, everyone. So for the final 15 minutes or so, I'll just be talking about a few things. So firstly, just going over some Shingrix and pneumococcal vaccination information. As we know, we've had Shingrix now as an NIP-funded vaccine for quite some time. It's a fabulous vaccine, provides a great level of protection against the herpes zoster virus. Just wanted to point out that with our shingles administration, we are getting quite a number of reports of at almost 50% of people experiencing at least one adverse event following vaccination. Now, that's across the whole of the country. So as you can see here on this AusVac safety slide, that we've had over 100,000 reports following Shingrix vaccination, and that almost 50% of patients are experiencing one adverse event. Now, there are some that are really, really common, as you see in this next slide. So local reactions are extremely common, as are fatigue and muscle or joint pain. Now, these are usually self-resolving within the first few days. But what we certainly wanted to outline tonight was about the reporting of rashes following Shingrix vaccine. So we are getting some reports around rashes, and the number one thing that we need providers to be doing is to please, first and foremost, eliminate herpes zoster as the cause of that rash. Now, information from TGA is that there is no noted increase of reporting of herpes zoster following Shingrix vaccine. However, the TGA is very interested in receiving these reports and following the data. So please, if you have a patient that has got a diagnosed case of herpes zoster following a Shingrix vaccine, please make sure you're reporting that to the TGA and also sending us a copy of that report. So that's all found online. If you have needing any information or direction as to where to find that information, please contact us at the PHU. Now, just bearing in mind that it's really important for patients to receive their second dose of Shingrix to be adequately protected. So please just bear that in mind. Now, if someone's had an active shingles virus case, the recommendation is that they have that vaccine, that second vaccine, 12 months after the first vaccination. So that's all in the Australian Immunisation Handbook. But again, please make contact with us if you're unsure. Now, the other thing we just want to touch on tonight is about pneumococcal vaccines. The Australian Immunisation Handbook has had some really fabulous updates in that chapter around pneumococcal disease, particularly some additions of infographics that are there now that are really, really clear and easy to read. However, again, if you have any questions, please refer to us. Just outlining that in Australia at the moment we have got 2 NIP-funded vaccines for meningococcal. The first being Prevnar 13, which is obviously a 13-valent vaccine, and the second is our Pneumovax 23, a 23-valent vaccine. Now, there are other vaccines on the market that are available privately by script, and that namely is the Prevnar 20 and the Vaxneuvance 15-valent Prevnar vaccine. There are some anticipated better protection with these 15 and 20-valent vaccines. However, like I say, they are not currently NIP funded. You can see here that they've been under development, and so just watch this space. But at the moment, if your patients are wanting to have those vaccines, they need to be having those by script. So again, this is just going through showing the really fabulous infographic in the Australian Immunisation Handbook around the funded vaccines. And apologies, actually, so there's an error on that slide. The private vaccines, that second box there in purple should be the 20-valent vaccine. Sorry, that was my error. And there's also some fabulous flow charts in these infographics. So if you have a patient that you're not quite sure what vaccine they need or what they're due, again, it's in the handbook and it's quite clear. And also information around people that have
previously received pneumococcal vaccines. So we have those patients that might have had a Pneumovax 23, an older patient perhaps, and then you're wondering now what I need to give them if they're someone at risk. So again, in the handbook, but again, if you're unsure, just give us a buzz. There they are, really clear and great flow charts. And I just wanted to make mention of this ATAGI statement that actually really clearly lists the eligibility around at-risk conditions and funding for meningococcal vaccines. So that's the ATAGI statement there, the link, so you can find that quite easily. Even if you just Google that, and it really clearly shows what conditions are considered at risk and whether or not those vaccines are funded for those individuals. Okay, moving on. So, righto, last bit of the night, guys. This is all about cold chain, and I know you feel like you hear this every single time we step up here, because this is a really, really important topic, and you will see as I go through these slides why we always talk about the cold chain. Now, we're coming up to summer, and we're coming up to lots of heat waves, storm activity, so we all know what that means. Often on Monday morning, we're getting lots of calls from practices and providers. Oh, we've had a power outage over the weekend. Help, please. We've got, 10 appointments booked in the next few hours. What are we going to do with our vaccines? So just wanting to go through some information about how we're managing our vaccines through the summer season. And of course, the other thing too, it's Christmas, everyone's busy, they've got their heads in other spaces, and sometimes you've got key staff that are out on holidays, they're off with their families, enjoying a bit of a break over the summertime. So again, this is also why we want to reiterate the importance of keeping an eye on these vaccines and making sure that we have staff appropriately trained in managing the cold chain. So some tips for the summer season. Always ensure our vaccines are stored between 2 and 8 degrees, obviously in a purpose-built fridge, in their original packaging. Now, domestic fridges, including bar fridges, are not built or designed to store vaccines and must not be used for vaccine storage. We occasionally still see that happening. Unfortunately, I don't think as much as it was years ago, but certainly there's some stories around that this occasionally does happen. So that is a big no-no. No domestic fridges, please. Monitoring the temperature is, of course, important. We're doing our twice daily min-max temperatures, and we're also downloading our data loggers once a week. Please don't overorder. Be really mindful that we are in this time of unpredictable weather, and that we don't want to have our vaccine fridges chock-a-block with stock. So just be mindful to, plan your ordering, and remembering that we are allowed to have 2 routine orders of vaccine per month. Prioritise delivery, just considering the timing of when to place orders in that month, and just being aware that the State Vaccine Centre will have a closure period. That's not up as yet, but it will certainly be the public holidays. Again, like I said earlier, consider staff leave. So if you've got your key practice nurse, for instance, who is the vaccine guru in your practice and heading off on leave for a month, make sure that you have other staff are adequately trained in managing the cold chain. Making sure that they can download that data logger, they know where the data logging is saved, and that everything is in order before that person goes on leave. Consider options for backup power. Does your facility have a generator? If they do, let's maybe test that and make sure it works. And of course, if we can, try and reduce the door opening of the fridge. So why do we always talk about cold chain? So vaccines become less effective if they're not stored correctly, and a loss of vaccine effectiveness is cumulative and cannot be reversed. And a big one, we need to mitigate the risk of loss of vaccine effectiveness due to avoidable human error. I've got some stats now for you. You might be horrified here. Here is a cost of about 15 months of cold chain breaches within Hunter New England Health and the cost of wastage of vaccine. So I will go through as to the reason for wastage in a moment, but this is about 15 months worth of data. We get quarterly data from the Ministry of Health outlining the cost of vaccine wastage for that quarter for our LHD. So it's quite horrifying that that's, over $250,000 there. Here are our reasons why we have that big wastage. Obviously, power supply failure is a big one. We all know that. Fridge malfunction, unfortunately, is also fairly unavoidable, but just ensuring that we are keeping good tabs on that fridge, making sure it's serviced annually, and doing all our calibration and checks. Human error. There you go, 25 cases, and then other. So when you look at that human error component accounts for about 20% of our reported breaches and then wastage. So that's fairly significant. Here are some of the reasons for our human error. Now, there's a bit of a pattern here. A lot of it is because vaccines were delivered and someone was told and they forgot that they were to tell that person that they had arrived, like your practice nurse, for instance, or they were left somewhere and someone got busy. We know what it's like in practice land. Sharon and I have both worked as practice nurses. We know how busy you are. But if you have someone on your front desk receiving vaccine delivery, that is a priority. They need to be ensuring that the nurse or the GP or the person that should be unpacking vaccines or even themselves is doing that as a priority. So other things are, that people don't have data logging, and we have no way then of seeing how those vaccines have been kept for a period of time. Power outages, people have been transferring vaccines into eskies but not monitoring the temperature in that esky. So we really need to make sure that those vaccines are constantly monitored, and without temperature data, we really have nowhere to go. And there's more. So you can see there, vaccine deliveries left unopened for hours on end, vaccines left on counters overnight, the delivery was given to someone else other than the person that normally accepts them, the door was accidentally left open, the door was left ajar. All these things really are unavoidable. So how do we avoid that human error component? We really need to make sure that our staff are appropriately trained in accepting vaccine deliveries. We need to review our fridge location and position. So if you do have a fridge that tends to have a door that can maybe stay open a little bit, maybe think about tilting that fridge. We need to make sure that we're servicing and maintaining and calibrating all our equipment every 12 months. And within that, we're doing our annual Strive for 5 self-audit. We need to know how to use the equipment, and we need to contact the PHU in the event of any planned, suspected or confirmed cold chain breach or excursion. Don't be part of the news cycle. I'm sure many of you have seen this pop through the news, that there have been practices across the news where they've had mass vaccination recall because their cold chain was not maintained. And unfortunately, that's significant cost and to community, not only financially, but also to confidence of vaccine and vaccine management. So just some extra little points and things to consider. If a patient needs to fill a vaccine script from a pharmacy, please ensure that the patient is made aware that the script should be filled on their way to their appointment to have that vaccine, or to be taken once the script's filled or the vaccine's taken to the practice to be stored in the appropriate cold chain. So again, don't make sure patients know to not pick up a script and then go put them in their fridge at home and turn up 3 days later for their vaccine, because that will not be sufficient. And just some feedback from a pharmacy, they actually said, is it possible for this advice to be added to the script perhaps? Now, who do you talk to about cold chain management, or what do you refer to? We need to remember that Strive for 5 is our national guideline. The use of web-based data loggers does not replace the guideline requirements. Information provided by data logger manufacturers is not always correct. If you have any questions or concerns at all about the cold chain management requirements, please contact us at the PHU. Key messages. Okay, so vaccines we know are super special and they do amazing things and they need really special care. Cold chain management is everybody's responsibility. The person that is going to the fridge to take that vaccine out to give to that patient needs to ensure that those vaccines have been stored appropriately. You need to report all cold chain breaches and excursions. The little disclaimer in there does not include temperature deviations where the temperature reaches a maximum of 12 degrees for 15 minutes or less. Now that's accounting for us restocking fridges and checking for expiry of stock. Ensure vaccines are checked in and put in the fridge when they arrive. We need to make sure we have an independent battery-operated min-max thermometer. Ensure your data logger is set for 5-minute recording and multiple staff now know how to download the logger and attach it to an email. Ensure no vaccines are stored on the floor of the fridge and always left in their original packaging. And please complete your annual Strive for 5 self-audit. If you have a breach at your practice, we will be asking sometimes for all this information. Okay, so resources, this is where we can find some great resources. So obviously, like I've talked about, the Strive for 5 guidelines there. There's a cold chain toolkit for immunisation providers, and also the vaccine storage and cold chain management training module should be done by everybody that is handling vaccines within your facility. Thanks very much.
Kirsty's just taking the microphone with her. It's okay. So thank you, Kirsty. Thank you, Kylie, Megan and Katrina. Fabulous presentations. Just going to finish off with a little bit of immunisation team news. Just a couple of slides. Some of you will have noticed that we have a new look web page. It's very different. You might find that you can't locate some of the information that you used to be able to find on our web page. We are working on it, but the most important things that you need to find are still there. So we now come under immunisation, allergy and immunology in Hunter, New England. To find us, you just need to look for information for health professionals, okay? And the two really important things that you will need to find is your adverse events form and your cold chain management reporting form. So if you just look under adverse events, it's going to take you to the New South Wales health page, but if you look at how to report an AFI, that will take you straight to our RegCap AFI form, which is what we'd really love you to use. Cold chain management is going to take you to the New South Wales web page, and then you'll find in the section it takes you to the cold chain reporting form. So please use those. We are working on our web page. We aim to see if we can make add some more information to it, which once was there. Most exciting news is we are hiring. So we are looking for a really enthusiastic registered nurse who holds an authority to immunise to join our team. So there is a link down there, but if you just search, I think it's New South Wales Health Jobs and look for us, you'll find it. But if you've got questions, just email Julie. She would love to talk to you, okay? And we would be very excited to see your applications because we're all about getting new people. Our staff has been slightly depleted over the last 12 months, and Kirsty and I are really excited to have more people join us to share our enthusiasm for immunisation. And we treasure all that you do. So thank you very much for listening, and I'm just going to hand over to Phoebe.
Thank you, Sharon. Thank you to all of our attendees. Before we even started, we had around 54 people just say hello to us because they knew that we were here, and obviously to each other. This is the reason this is one of my favourite events, because you guys just make it so wonderful. The interactions, the questions, just great. So thank you. Thank you to our wonderful presenters. They are busy enough without having to add more to their workload, but they take the time to create these presentations and present them to us. And we're just so lucky and appreciative to have them as a resource. The recording will be put on the PHN website in the library in the next 2 weeks or so, hopefully sooner, but in the next 2 weeks. Please complete the evaluation that would have popped up on the right-hand side of your screen if you want a certificate. Please be patient to receive your certificates, because always I'll walk into work the next day after finishing late and there'll be an email in my inbox being like, I did this, where's my certificate? It is a manual process from my end, so please be patient with me. Other than that, we won't see you until next year at some point. So have a happy and safe holiday season and take care of yourselves. Thank you.